The CHA Gold Innovation Fellowship is a mid-career professional development opportunity here at CHA, made possible by an investment by our CHA senior leadership team and by the Arnold P Gold Foundation. This is the end of our first year, and we had 5 fellows who were chosen because they are emerging leaders here at CHA, clinician leaders. The fellowship has 3 aims. It seeks to nurture the personal and professional development of fellows. Number 2, it seeks to bring about positive institutional change through 2 mechanisms. First, by supporting the successful accomplishment of specific change projects. The second way in which the fellowship tries to bring about institutional change is through the creation of a community of practice among the fellows. And third, the fellowship seeks to experiment and play with this idea of co-production, with this notion that at the core of the healthcare enterprise is a partnership between patients and families and health professionals. And any health outcome that is produced is inevitably co-produced by that partnership between patients and families and health professionals. And so the idea is that if we want to improve health outcomes, one of the ways that we can do that is by strengthening the partnership between patients and health professionals.
We recognized that we wanted to help our patients improve their high blood pressure, get it under control. And to do that, we started utilizing nursing and pharmacy visits with our wonderful nurses and pharmacists, using a co-productive lens, which we worked on especially with our nurses. And so during this past year and a half, we've been spreading that and have had it spread throughout all of our primary care clinics.
There are people who don't mind being on medication, and especially people who grew up in the US, and I know I'm saying that, but I'm very careful because, you know, it's kind of normal because they've seen their grandmothers take medication, like someone is old, they have a pill box. We don't have that in my culture. We have old people who take no medicine. So the only people who take medicine is like if you have asthma, if you have HIV, which are big diseases, and it's normal to take medicine. Eventually, my goal is to get off of the medicine. And you asked me a very good question. You asked me, so what do you plan to do? How do you want to accomplish that? That was a good question, because it's basically, this is what you want. How are you taking accountability for that? So when I had a follow-up with Mary, she went into the notes. But you know, I can see you have goals. So what are you doing with your goals? As if you have to see the doctor, and then you see the doctor the next time and the third time, you kind of like have a serious situation. It's almost like the big disease where you have to see the doctor. But when you see the doctor and you see the nurse, you feel like, okay, I have a disease, but we're kind of working on it. But it's not really a very big thing. When you feel like people are rooting for you, like to get to a good place, and they're not just telling you what to do, but you feel like someone is saying, hey, you know, maybe you could do something that might make it better for you. It just feels better.
As Massachusetts has been getting ready to certify community health workers, we saw a need to develop community health workers here at Cambridge Health Alliance for some specific reasons. One is we are actively trying to expand our patient panel, and especially amongst vulnerable immigrant communities. And we thought that a good way to do that might be to work with people from these communities as community health workers to try to engage people who have not otherwise been involved in care.
So I oversee the Volunteer Health Advisor Program. It's a network of about 40 community members who are trained at CHA to go out and perform health screenings and offer health education. Many of them foreign-trained health professionals, a lot of them laypersons and educators. Our model was really to go out to, often to where people pray, to mosques and churches. So our group was comprised, the group of 40 that we have, I think had about 20 different countries of origin and 14 different primary languages.
I am from Syria. I did my medical school back in Syria, and after I moved to the state, so it was really difficult for me, and for all people in the same situation like me to know about the healthcare system and how to get back to our career to work as a physician. To me, it was really such rewarding, helping immigrants and people who don't know how to access healthcare, to help them, to link them to hospitals and to primary care physicians.
Between a Latino to a Latino, obviously he's gonna trust on me because I'm actually telling him, hey, I'm in your side too. So I'm actually telling you, you're gonna be okay. Trust me. So I'm giving him my trust, right? So I'm giving him my word that you're gonna be okay. So it's actually, you can get a bunch of emails and you can say, hey, you can get health insurance if you apply here, but many of them, they won't apply, right? So you have to actually encourage them to come over, apply.
I think it was very bi-directional, right? I mean, it was there's a lot of mutuality in the benefits. So when you look at it from the volunteers' perspectives, as Rowan mentioned, a lot of the volunteers, were not they themselves were not familiar with the U.S. healthcare system. So this was a way for the volunteers to become familiarized. Yeah. And as I said earlier, a lot of them were really mal-employed. These were really smart, really talented people whose energies were going into, important things like babysitting, or they may have been in construction or house painting or working in a restaurant. But this was really the opportunity to do what they trained for back in their home countries. And I could sense in a lot of the volunteers sort of a regaining of their dignity through the work that they were doing, and this feeling of being back on the right path through this program.
Yeah.
The first part of the project is focused on the clinicians and provides real-time clinical decision support embedded in the electronic medical record. The second part involves a shared decision-making tool that facilitates a discussion with the patient and the provider and all the members of the care team, so that the patient's perspectives are taken into account when we're thinking about how we think about their risk for bad outcomes.
Having the physician, the nurse, and the patient together to have this discussion is critically important, because one of the challenges of the emergency room, the patient feels very vulnerable. They're in for what they consider a crisis, so their anxiety might be high. They're not hearing things quite as well. The physician is under a time crunch, trying to do several things at one time. The nurse is able to have a little bit more time with the patient, develops this relationship with them. The patient often will feel more comfortable bringing a question to the nurse, doesn't want to admit to the provider they don't understand, or that they are not able to deal with the situation. So I think it's essential that all of the people sit together at the same time, because I can help the patient represent their perspective a little bit more. As the nurse, I can reinforce what I heard you say and try to have a more informed conversation.
I think involving the patient will definitely allow them to voice their concerns, be involved enough to ask the right questions, because they have the other members of the team there. It's not just the doctor dictating to them in a short period of time without feeling like they have the support of anybody else, be it their family, be it the nurse, the person who did their EKG, somebody that they kind of felt a little bit more of a connection with sometimes.
So the COPD Rescue Pack is essentially an antibiotic and a steroid. It's a 5-day course that patients take when they've been admitted in the hospital, or if they had gone to the emergency room for a COPD exacerbation. Patients have been very excited about having the antibiotic, about having the steroid, about having the medication at home to use it when they need it. It allows them to take control of their own health, to be a part of managing their health, managing their care, and they almost look at it as a partnership between their primary care team.
This is an idea that's been used for a while by individual clinicians, especially pulmonologists, but it's never really been used on a larger scale approach. And based on some initial early successes that we've had here at Somerville Hospital Primary Care, we really thought that it would make sense to roll this out across the entire Health Alliance. So we now have introduced the program at all of the 10, 12 different primary care sites, and we're beginning to collect some data to see how effective this approach really is on a larger scale.
The Wellness Recovery Action Plan was designed by Mary Ellen Copeland. It's a very plain plan. It talks about what do I need to do every day to take care of myself, the daily maintenance plan. And so you think about there might be 3 or 4 things you're going to do every day to take care of yourself. And then that gets spread out. What's a picture of wellness? What do I look like when I'm well? And the first part of the crisis plan is, do I look like? What do I look like right now? And you go back and you look at your picture of wellness and say, oh, this is not how I usually am. Mm. It's so just self-empowering. It just makes you feel like I can do it. I'm good by myself. I'm okay. I'm a good person. And there's nobody there who can say you're not. So where do we ever kind of get that?
So the idea of having a resource that people can commit to in a more flexible way and is there week after week, and not a substitute for treatment, but a way to hold people and help them manage and help them navigate the system.
I guess starting last late winter, probably, trying to integrate and adapt the principles of RAPT for a substance recovery group. Working with one of the other therapists to develop a sort of curriculum that helps structure around the core principles and the core philosophy of RAP. I think there have been certain challenges with that in terms of it's not a peer-facilitated group, it's a group that I facilitate, so it's a RAP-informed group. I think it's been really well received in the sense of it definitely feels like something new, and I think patients are feeling very valued in terms of what they come to offer.
So we've come to the end of our first year, this inaugural year of our CHA Gold Innovation Fellowship. And I think that each one of the 5 fellows has grown, has learned things that they didn't know about improvement science, about partnering with patients, about leadership. And the group has really become a little community of practice, which was our hope. The relationships between the fellows have grown over the course of the year, and now somebody in the emergency department has a friend in the primary care that they can turn to, or somebody in primary care has a friend in psychology that they can turn to troubleshoot ideas and to work together on solving problems. Each one of the fellows explores a different aspect of this concept of co-production. Goal setting and the importance of having health professionals serve more as coaches than as traditional healthcare providers. The power of shared decision making, the power of enlisting patients in self-management to a much greater degree, letting patients decide when they need to start medication for a flare of their chronic condition. And inviting patients to help one another through peer recovery groups. And each one of these projects has actually laid the foundation for other projects that are built on the same template. So we can use, for diabetes, the same model of coaching and goal setting that we developed for hypertension. We can use peer recovery groups not only for depression, as they were initiated during this fellowship year, but also for substance use disorders. We're in the process of developing a rescue pack for patients with heart failure, not just for patients with COPD. So in many ways, the experiences that our fellows have had this year have made additional change possible within the system. Change is an iterative process. We just finished the first year, and there are so many lessons that I've learned in the first year that will inform the way I think about the second year of the fellowship. Second year fellows are actively engaged as mentors to the first year fellows. And hopefully the fellowship itself has nurtured the soil here at CHA so that as an institution we might be fertile ground for new change ideas, for better partnership between patients and health professionals and better partnership among health professionals.